Hello and welcome. My name is Raj Persaud and I'm a consultant psychiatrist based in London. And this is part of a series that we're calling Headstarters, where I have a chat with several psychiatrists who are young psychiatrists in training to find out what it's like to choose psychiatry as a career. And joining me today are Amy, Yusuf and John, who are all young psychiatrists in training. And we're talking a little bit today about what attracted these young psychiatrists to choose psychiatry as a career in medicine, and what in particular was it about the image of psychiatry that drew them to the discipline. Let's start with you, Amy. What was it that drew you to psychiatry?
I think for me it was probably that you actually got time to speak to your patients and take into account a lot of factors such as social factors and psychological factors and how they interacted, rather than purely focusing on the kind of medical aspects of illness. And you seem to have a lot more time for your patients in psychiatry than in other specialties.
So some people have described psychiatry as being more female-friendly than other specialties. Does that have any meaning for you as a statement? And is that part of what drew you to it?
To be honest, I don't know whether that influenced my decision consciously. Probably, I guess it does have meaning in that there, obviously in psychiatry there are elements that suggest that it is female friendly. For example, I guess since I started training in psychiatry, there have been 2 female presidents of the Royal College of Psychiatrists, which I guess in other specialties perhaps you don't have that, and having those women in high-powered positions, I suppose, is a very positive kind of role model. I guess that's not necessarily a conscious thing that ran through my mind when I was deciding what specialty to choose, but perhaps it did play a role subconsciously.
John, what about you? What drew you to psychiatry?
Yeah, I remember I was doing my A-levels when I was about 17, and I got chatting to this man and got to know him over about 2 years. They sort of revealed to me that he'd got schizophrenia, and sort of he knew I was going to medical school, and he said, "Why don't you become a psychiatrist?" And being about 17, 18, I didn't really give it a lot of thought. Read a bit about the speciality and thought, this seems interesting. And really all sort of stemmed from there. The more I read about it, the more fascinated I became. Did my placements in psychiatry, did an elective in psychiatry, and pretty much confirmed that this was the career for me. I never really sort of thought about it from whether it's a sort of female-friendly speciality or a male-friendly speciality. I was really attracted more just by sheer interest and curiosity.
What in particular did you find interesting or about it, or what stimulated your curiosity?
I think it's got a nice sociological aspect to it. You're dealing with a very wide variety of society. You're examining people's religion, their politics, their different outlooks on life, their views. Whereas you just don't sort of get that personal touch, I feel, as you do perhaps in medicine or surgery. So I think you're really looking at people truly as individuals, rather than just the appendix that needs to come out or the pneumonia that needs antibiotics.
So do you think that as a result psychiatry attracts a different kind of person than other medical specialties?
Yeah, I think psychiatrists are certainly very different, distinct personalities from physicians and surgeons, and that's not necessarily a good or a bad thing. And individual doctors will of course have their own interests, but I think to be a psychiatrist you have to be quite curious about how people think and what makes them tick.
Okay, and what about you, Yusuf? What was it that drew you to psychiatry as a specialty?
Well, I'll try to be as honest as possible, because it's a bit of a journey that I went through. Coming from a family of doctors, I was sort of, I wouldn't say pushed, but I sort of shown the light as in this is the profession that you should be doing. This is the right thing to do. So from a very young age, on my 6th birthday, my dad brought me a doctor's kit and took a lot of pictures, and then showed it to me later on in my life and said that this is what you wanted to do since you were a kid, which is quite contrary to what I actually wanted to do. However, after sort of...
Well, wait a minute, I've got to stop you right there. Was your dad a psychiatrist by any chance?
No, he wasn't actually. He was in pure medicine, pure respiratory medicine. So it was So when I joined med school, very proud, very happy. I saw all the specialties. Nothing really struck my interest, but it was really in my 3rd year of medical school, and I had contact with a patient who was a schizophrenic. That really struck my interest. Very, very fascinating. Very interesting to see how unwell he was and how well he reacted to the medication. And that really drew me towards this specialty. Then coming on to your second question, really, is it female friendly? When I talked about the idea of pursuing this as a specialty, it wasn't really, I wasn't really, my family wasn't really taken to the fact, wasn't too, how would I put it, wasn't too impressed by the idea that I was actually pursuing the specialty. And I really questioned to myself, why is that? It's a noble profession. You're really helping people who really need help. But a lot of people had the view that are we really? Is there any science to what we're doing? Is there any blood test that you can check to see whether a patient is actually having a certain disease or disorder? And really, that made me more, instead of drawing me away from the specialty, made me more defensive, actually, to say that fair enough, it's evolving. There's a lot of things that are going on at the minute. There's a lot of research involved, but there's definitely something behind why a patient presents the way they do. And to sort of say that, well, should we really pursue this specialty? I became very defensive, and I sort of read more into the subject, understood more about why patients present the way they do, and I sort of gravitated towards it. And I'm very happy that we're having this discussion today, and hopefully we'll make something fruitful of it, because I really strongly and passionately believe that people have a very different image or perception as to what we really do and what this subject is really all about.
I get the feeling that you're kind of suggesting that your parents or your family that were already in medicine were somewhat disappointed that you chose psychiatry. Do you think they would have been disappointed if you went into any other specialty, if that's what you're saying? And therefore, isn't it interesting that there's something about psychiatry that a lot of mainstream doctors don't think of as being proper medicine? Is that what you're sort of saying, Yusuf?
I mean, that's, yes. That you could say in that way. I wouldn't really use the word disappointed. Probably my father would may have liked it more if I was to choose his own specialty, which may usually happen in a lot of other families. I can understand and appreciate that. But yes, in psychiatry in specific, not only from my father but from my relatives, from people around me, my father's friends were all doctors. They did have that perception. You did really have, when you're sitting on a dinner table and having a discussion, it did come up, well, why did you choose psychiatry? And that question wasn't really asked particularly to other people who had chosen other specialties. And it sort of did make me think quite a bit when I was actually in that position of choosing specialties. Yeah.
Amy, I want to ask you something, because both John and Yusuf seem to be drawn into it by meeting someone, and I'm paraphrasing now, and I may not have got this quite right, who seems to have been a bit psychotic, and that experience of the wonder of psychosis, as it were, seems to have drawn them in. I wondered if you ever had a similar experience, or do you think, because some people find meeting someone who's a bit psychotic quite disturbing, and they want to sort of run away from that person. They don't want to get drawn into understanding them in greater depth. Do you think there's something about that that separates psychiatrists from other people who are drawn to it?
I guess if you're somebody who finds that particularly anxiety provoking, or, I think there's a lot of evidence, isn't there, that if you have a negative experience of psychiatry at medical school, then, you tend not to choose that as a career. And I guess part of that is what you're going into your medical school consultations believing about mental illness, having preconceptions about psychiatry as a specialty, and perhaps that would make you feel more anxious if you're in a consultation with someone who has psychosis, and then perhaps it plays out that way. But I mean, certainly when I was at medical school, I had quite a lot of really interesting interactions with people with psychotic and non-psychotic disorders that kind of inspired me to go into psychiatry. And so I would be more inclined to think it's more about how you go into those consultations, how safe you feel, how well controlled you feel the environment is, and a lot about your preconceptions about psychiatry and mental illness and all the, stigma that can come with that, rather than kind of an innate somehow preference for psychiatry or not.
And is there a link there with the female-friendly theory or idea that women are often more interested in, they say, although this may sound a bit sexist, in terms of, compared to men, in terms of listening and understanding? Whereas men may be more surgical, they just want to get in there and take the problem out? Or is that a very sexist approach?
I mean, there is that idea, isn't there, that women are more like this and men are more like that, and I guess you hear comments like that all the time. But I think in reality that's no more true than making any other kind of judgments about any other group of people. It's not actually true on an individual level. There's a kind of wide range of women. Some prefer to do other specialties. Some have more empathy, perhaps better listening skills, better communication skills, whereas some prefer other aspects of medicine.
John, if it is understood that psychiatry might be more female-friendly, do you think that puts men off choosing psychiatry by any chance?
I think that what medicine, certainly since the European Working Time Directive and modernising medical careers has come about, and had this discussion quite a lot, is where the old school would have done a 100-hour week, and now we're working sort of 40, 48-hour weeks. Doctors, I think, are a bit more focused on lifestyle, and a number of them are saying, do you know what, I don't really want to work 1 in 3 weekends, I don't really want to do every other night, and they're thinking, actually, I would like a life outside of medicine. And I don't think that psychiatry is explicitly female-friendly. I think it probably allows a great deal of flexibility that other jobs don't allow. I was having a discussion with Yusuf earlier that perhaps when you're a psychiatrist on call, you might just be able to give advice on the end of a phone, whereas, say, if you were a surgeon on call, you can't do the operation from home. You have to physically be there. But there are other medical specialities that are lifestyle friendly. Pathology, dermatology, rheumatology, general practice. And I think that, as again, speaking to Yusuf earlier, pathology, I believe, has quite a recruitment crisis, but you don't really need to be an on-call pathologist called in the early hours of the morning. So I think what psychiatry really offers is perhaps a greater flexibility and lifestyle, that you can pursue your interests and hobbies outside of medicine. You can spend time with your family that perhaps other specialities just don't afford.
But I guess that there's kind of a massive difference between something being female friendly and something being lifestyle friendly. And I think perhaps you know, 20 years ago or longer ago, maybe people would consider that women in a more traditional role and that women should choose specialties where they can bring up families and things like that. But I really hope that now that isn't kind of the prime motivator for people to choose a specialty, because obviously now there's a lot more kind of equality in terms of bringing up families. And I think the idea of calling a specialty female friendly when what you mean is it provides a good work-life balance is only kind of adding to implicit gender biases that kind of aren't necessarily particularly helpful in the long run.
This is something that I personally have quite a bit to actually talk about, because if there is any bias possible, I think it's not the case in my family, because my missus, she's a surgical trainee and I'm a psych trainee, and we often get asked the question, what is going on here? And in my defense, if I was to take psychiatry as a specialty, if I think the sort of person or personality type my wife is, if she was to do psychiatry, she would struggle tremendously. No disrespect to her, she does really well at what she does as a profession. But there is a certain personality type that is specific for psychiatry. And fair enough, we talk about it's not physically draining, you get home on time, you have more time you can give more time to your family, but it is very mentally draining at the same time, and that's something that people probably don't take into consideration. Your mind is occupied about a lot of things, a lot of decisions that you've made throughout the day. And you have to be quite strong-headed about that. So I really don't think that there is a gender bias or that there should be a gender bias. I think it attracts a certain personality type, whether that be male or female. I think this discussion usually comes up because a lot of people have this preconception that females are more emotionally connected, and hence they might be better suited to this profession. However, I have my own thoughts on that, but I don't want to divulge in that. But overall, my own personal opinion would be that people who have done this specialty have the understanding that it is taxing. They are on calls, unlike other specialties, especially section assessments, peer doctors having to go out in environments that they're not familiar with, taking risks for the benefit of other people. And I don't know why that's not appreciated.
But what you're saying is very interesting, because it goes back to this thing we're discussing about the female friendliness of it. You said that you're a psychiatrist and your female partner, is a surgeon, and it raises a query in when they meet you, in people's heads. They think something's not quite right here, or they find it surprising, which tells us there seems to be a gender bias.
Absolutely. In
the way people think about specialties, I think. Let's just talk a little bit about the emotional draining thing, because there's a sense in which that seems to be part of the stereotype. I think one of the things that makes psychiatry particularly challenging emotionally is that you take a lot of responsibility. You're often making very high stakes decisions where if bad things go wrong, really, really bad things can go really wrong. And yet your ability to control the outcomes is very reduced compared to the rest of medicine, where if you're in an operating theatre, you seem to have more control over the outcome. But I don't know what the three of your experience of that is, or what your thoughts are about that.
Yeah, I think that's true. I mean, there are, obviously, when you're seeing people, particularly, I guess the classic example would be somebody who's suicidal, and you're there to make a judgment about, or part of your role is making a judgment about, say, whether they come into hospital or not, or what treatment that you're going to provide. And obviously, if you make the wrong judgment, then the outcome could be death. And I guess that's something, because it happens quite almost a distance in time and indeed in place away from the decision that you've made, then you are less able to have control kind of over that decision. But I think that it's how, I guess there are different ways that you manage that, and in psychiatry there are kind of support systems in place to help you, obviously firstly in terms of your training, to be able to make decisions that are correct, but you're never going to be able to do that 100% of the time, unfortunately, without being unduly restrictive on your patients. And but there are kind of like balance groups and things like that, and you have to be able to open up about your own kind of feelings towards things, and when things do go wrong, even in more kind of minor ways, and I guess more reflective in the way that you practice, perhaps than in some other specialties.
Yeah. But I want to pick up on that point, because I think that this is where I think Amy and I have disagreed in the past. I think that when you have to see someone at 3 o'clock in the morning in casualty and make a decision about admitting them because they may be suicidal, and you've got to get that right, that decision, I think that what's stressful about that is, even if you should try to admit them or you want to admit them, the admission process is a bit of a nightmare, in terms of someone has to go and find the bed, and it takes a long, long time, and there's a subtle or not so subtle pressure on you not to admit people. And I think as a surgical registrar in casualty, if you want to admit someone because they have acute appendicitis, it seems to me to be easier, and people don't quibble with you so much about that. But I wonder I mean, it's a long time since I've been in that position at 3 in the morning, but I wonder what the rest of your experience of that is.
Yeah, I think what psychiatry makes psychiatry very different is you almost are assuming the responsibility and the risk that for someone else's actions. You know, you're making the decision whether somebody should be detained or whether, you know, they can go back into the community to be treated. But if something goes wrong after that, you know, they look back and apportion the blame to you. Whereas perhaps in medicine or surgery, if you cut the wrong artery or give them a bit too much of an antibiotic or something, you know, you can directly apportion it. But if the diabetic patient isn't very compliant with medication, they don't really blame the physician for it. They say the patient has the choice. So I think psychiatrists are quite unique amongst medics, in the sense of they accept a lot of responsibility for other people's actions.
Yeah, I agree. That's very stressful.
I have my own opinion about, I mean, we usually talk about the pressure of beds in psychiatry. It's a very common topic of conversation. There's two ways to look at it, in my opinion. You talk about the sort of incident where a junior doctor is on call in A&E and is having to make that decision. I would say that it is quite, at the same time, helpful in a way that people are taking those positive risks at an earlier stage in their career, and this pressure of beds has sort of taken the defensive element of psychiatry, has pushed that away just a bit, and rather than admitting everyone, keeping everyone in hospital for longer than they actually have to be, the pressure of beds is actually not too bad if you look at it in that particular perspective of doctors thinking about decisions twice and making these decisions in their head and being trained in that way, so that when they actually have to make those decisions, they're taking everything into perspective and seeing what would be most beneficial for that patient at that point in time.
Yeah, but Yusuf, I got to take issue with you there. I mean, I think you're making a very valid point. But one of the reasons why I found it very stressful staying in the NHS and decided to move into private practice, which I work in full time, was the fact that you would admit people to the very scarce bed, and then the managers would come along and move that person to somewhere else, usually West Yorkshire or somewhere very far away, to create a bed for someone else. So people were never on the ward for long enough to receive proper treatment. They were constantly being moved around like chess pieces all over the southeast of England as a result of the bed crisis. So the therapeutic environment provided on the wards, in my view, completely disappeared. But again, you know, you guys.
I don't know that that's entirely true. I haven't had, maybe in the southeast that it's different, but I guess where I've worked, although there has been incredible pressure on the beds, and I agree with Youssef that when you're choosing to admit someone at that point of contact, whether that be an A&E or a mental health assessment, then yes, you can be challenged, and I agree with him that to some extent that's helpful, because I think when you're starting off, you can have a tendency to be quite risk averse and not really think about the potential consequence of admission and the potential negative consequences of that, increasing dependency and institutionalization of patients. But when people have actually been admitted onto a ward, then I haven't had the experience of them being moved across the country. Generally, they remain on the ward unless there's a reason that they need to move. For example, they might need to move to a PICU, or
they're not,
there's a clinical need.
They're not admitted in the first place. There's no beds in a specific area, hence.
So they'd be admitted elsewhere.
Out of area. But the only thing I have to say to that is that there are two ways of looking at that problem. In a way, yes, it's problematic if it was your friend or a close relative. At the point when they have at the worst point in their life, would you want them to be out of area, away from friends and family? You wouldn't personally. But at the same time, would you want that person to be in hospital for months at a stretch, and then for them to get used to that surrounding of a hospital as, let's say, their natural habitat, and then the complications and the consequences of that to themselves whenever they have another problem or catastrophe in their life? What would they start thinking? Should I just go into hospital for another 3 months for respite? And how would that actually affect the services that we provide? Would we be taking care of people who really don't need to be taken care of? And that is a massive question that pops up in my head.
Yeah, so I don't think bed pressure is not just unique to psychiatry. I've just finished acute medicine, and there's a real pressure in medical hospitals to discharge patients perhaps sooner than they should be, and they get moved from one ward to another, and then they move to another because somebody needs a side room. So I think bed pressure is not just unique to psychiatry. I think it is quite widespread within the NHS.
I guess, though, Raj's point about the expectation that actually when you see people in A&E, the expectation is that the majority will not be admitted, whereas in other specialties, if there's some degree of uncertainty, say you're the F2 on call, or the SHO on call, and your registrar, the next most senior person, is in theatre and you're not sure about something, then you could potentially admit someone until they've been kind of reviewed or overnight to get a period of assessment, whereas you don't have that kind of luxury in psychiatry.
But there's also another dimension here, which is that you arrive in casualty as a patient very seriously ill in some way, you're feeling pretty unwell, and the doctor says, I think we should bring you into hospital. Guess what? You tend not to argue too much with that. In fact, you're fairly grateful to be admitted, or you just go with the doctor's opinion. Now, transpose that to psychiatry. Someone is experiencing some very, very horrendous emotional turmoil or trauma. They arrive in casualty. They're already under a lot of stress. Just being in hospital in the casualty department on top of the stress of whatever they're going through, and then for a hospital admission to be suggested is not usually terrifically popular. And then the process of producing the hospital admission, if you have to go around trying to secure it, which is quite stressful for the junior doctor or the doctor, adds a layer of stress, which I think is profoundly unhelpful when you're trying to persuade someone to come into hospital when they're in a deep crisis. And that is one of the reasons why, largely speaking, inpatient units are turning into places where only people who are sectioned under the Mental Health Act end up. Because, and that's not great for psychiatry, in my opinion. But this is my opinion, and the three of you may differ in your view on that.
No, I completely agree. It is very stressful. Like I put the analogy of it being my relative or someone who I know personally. If they were in that situation or on the verge of admission, the doctor making the call that they need to be admitted, and then having to go through that strenuous process and the possibility of them having to be sent out of area is extremely stressful for that individual. And yes, this definitely should be something that should be done about that. But at the same time, once the patient's admitted onto the ward, for them not to overstay, or for them not to be in hospital for longer than they have to be, is probably a positive thing for the mental health. It's probably not such a bad thing. That's the point that I'm trying to make.
I guess there's also the question of why is it stressful to get a bed? Why are once the decision's been made, why is it questioned? And I guess there's probably a lot of different opinions about why that might be. If it is purely kind of bed pressures and the question is, why is anybody being admitted? Because there's these pressures, and the people that are having to find a bed are under pressure, and that's kind of transferred down to the doctor that's working in A&E, and that's kind of got quite negative connotations. But if it's because actually there's not so much of a strong hierarchical structure to psychiatry, that actually other your colleagues and other staff that work in mental health feel more able to challenge your decisions and have open discussion about those decisions, then I don't know that is such a kind of negative thing, that actually doctors' decisions can be challenged by non-medical staff. And I think that probably does happen more frequently in psychiatry than it does in other specialties, because you don't have such a strong hierarchical kind of thing.
Yeah, I agree that there's that difference, but I want to take issue with you in that I think it's a really bad thing, because guess what happens? What happens is you decide to admit someone, and it's very much more difficult to make that decision clearly, because should you say to the patient, I think you should come into hospital, you're at the beginning as a doctor of a long journey of having to fight and argue now with the managers and the social workers and the nurses to make that decision happen. But should something go wrong, they all flee for the hills and they come and blame you when things go wrong. You have to take responsibility when things go wrong. And part of the stressful nature of psychiatry is they don't let you make the decision, but they come to blame you when the decision goes wrong, despite the fact they won't let you make the decision. One of the reasons I had to leave in the end was the fact that I was no longer making the decision over whether to admit people or not. We had to refer them to this dreadful thing called the home treatment team. And the group of people who had never been to medical school made the decision about admission. And then when I tried to discharge people from the ward, again they were referred to this dreadful thing called the home treatment team, and they made the decision about discharge. So frankly speaking, towards the end I thought the only reason they had me in the hospital is to find someone to blame or to send to the coroner's inquest.
I mean, Raj, I think you talking about this problem from a consultant's perspective, something that we haven't.
That's right.
something that we haven't.
Did you detect a bit of burnout there, by any chance?
No, and that's something that we haven't sort of gone through firsthand. I think that's the difference in the perception at this point, and that's why we probably have a difference of opinion. But I know time is of the essence, and we sort of drifted away from our initial topic of discussion. The only thing that I wanted to say today is why has the sort of image of psychiatry strayed in such a way that these are the only thing that people are focusing towards, the negatives. And I have something to say about that. I think recently everyone knows about the achievements Dr. Steve Peters has made. And I think that's brilliant as to what he's done for the British cycling team, for Liverpool Football Club, for the England football team. And I think that is the image of psychiatry that we sort of need to embrace and portray to the general public. You don't have to be mentally unwell to gain the benefits from what this specialty has to offer. And I think if this image is portrayed to a lot of medical students, a lot of foundation year doctors, that you can do wonderful things with this specialty. It's not all about bed management. It's not all about the bureaucracies of the system. and to look at it from a different perspective, I think that would really change a lot for this specialty.
Except that I'm not sure the person you mentioned is a psychiatrist. That's a term that's bandied around often in the media in an unclear manner. They may well be, but psychologists and psychiatrists are often confused. But I agree with you that it is a wonderful specialty. Sometimes we get bogged down in discussing the ins and outs of the administrative element, but that does come to dominate some people's lives. But we're running out of time, as you quite rightly said, Yusuf. John and Amy, there may be some other concluding comments you may want to make.
Well, yeah, I mean, I think Steve Peters is a psychiatrist. But anyway, yeah.
Yes, I'm reading his book at the moment.
Good. I'm glad we got that sorted out.
Yeah, no, I guess I agree that perhaps some of the focus of these sort of podcasts does suggest that we do tend to focus on perhaps negative aspects of psychiatry, when perhaps we should be looking at more positive. But I guess in terms of our day-to-day work, we do work primarily with people who do have mental health problems rather than kind of athletes and sports stars. And I think that in itself is, I don't think that's something that should be overlooked, although, and I think it's something that's very rewarding in itself and something that can, the specialty itself can offer medical students a lot if that is something that they're interested in, and if they're the type of person, regardless of what gender they are, that would enjoy kind of those sorts of aspects, and seeing people getting better who are struggling with really hugely limiting and debilitating illnesses, and also people who are interested in research, just going back to what Yosef was saying, that people can perceive that it's not particularly evidence-based. But actually, for me, one of the interesting things was the scope for research into psychiatry and how much can dispel some of these myths that it's just for people who kind of are a bit softer and are less logical. I think that those are complete myths, and actually people should consider going into it as a specialty and certainly getting some experience in it.
Yeah, I think that Henry Miller, the neurologist, once said that to be a psychiatrist you must first be a physician, that secondly you must be a superlative physician, and it requires diagnostic virtuosity of the highest order, something sort of along those lines. And actually, psychiatry does require a great deal of knowledge about physical medicine, neurology, to perhaps exclude that this isn't an organic cause of the presentation, that actually this is a psychological cause. So it does really require a fine degree of clinical acumen and clinical skills. But I think really sort of to add to what Amy has said, I'd really encourage medical students and doctors really to choose a specialty they think that they would be happy in first and foremost, rather than what they think that the stereotype of a surgeon, of a GP, of a psychiatrist actually is. That really, if you're going to do a job for 40 odd years of your life, you want to be happy, you want to be comfortable in it.
John, thank you very much indeed for that. So we're running out of time. I just want to spend the last few moments of the podcast to thank John, Yusuf and Amy for taking part. I particularly like the fact that what tends to happen in these podcasts is I play the role of the grumpy old man, and I invite you all to partake in my rancor over some aspects of psychiatry, and I'm really very enthused by the fact that you never fall for my bait, and all of you stick up for psychiatry, and fight for your enthusiasm for the subject, despite my best efforts to put you off. But I too enjoy being a psychiatrist. I just want to push back at the three of you, and you push back at me very effectively indeed. And I think that your enthusiasm comes over, and I hope many other people listening to this, particularly medical students or people studying at A-level or people who are already in a particular branch of medicine, consider the most exciting specialty in medicine, which is psychiatry. Thank you very much indeed.